Welcome to Medscape's latest podcast series, Medicine and the Machine, featuring Medscape's Editor-in-Chief, Dr. Eric Topol, and Master Storyteller and Clinician, Dr. Abraham Verghese. Remember, you can find the latest in medical news, expert perspectives, clinical tools, continuing medical education, and more at medscape.com.
Hello, this is Abraham Verghese, and I want to welcome you to a new episode of Medicine and the Machine that I co-host with Eric Topol. My great pleasure to do it with him. And today we have a very special guest, someone that I've looked up to pretty much all my career, and that is Arthur Kleinman. He's a professor of psychiatry and of medical anthropology at Harvard University, and I think carved out new territory early in his career by creating this field of social medicine and medical anthropology, literally putting that on the map and training some notable students who've gone on to do great things, including Paul Farmer, to mention just a few. Arthur is the author of many influential books. One that truly informed my thinking was the illness narratives. But he has a book now that I'd like to talk about with him, we'd like to talk about with him, and that is The Soul of Care. So, Arthur, welcome to this podcast. Thank you so much for doing this with us.
Thank you, Abraham, for having me. I'm delighted to be here.
I thought it might be helpful for us to begin by you're telling us how you got into this field of medical anthropology, social medicine, how it evolved briefly, how your career began that way.
Well, I was one of those strange types that who, when he went to medical school, could have gone somewhere else. I could have gone to graduate programs in the arts and sciences. I was always very interested in history and in social theory. And after I had been in medical school and then gone to the NIH, and from there was sent to Taiwan during the Vietnam War as a U.S. Public Health Service officer, I became very interested initially in the issue of how medicine was carried out in different cultures. After all, I was from the United States and I was in Taiwan, and I saw a radically different healthcare system and distinctive ways of caring for people. And so since my late wife was a China scholar and I knew Chinese, I thought that I should really attend to culture in a deep sense and become an anthropologist. And that's what I did. I went from Taiwan to Harvard, studied social and cultural anthropology, and helped develop the field of medical anthropology. And I guess the distinction I draw is that you are, in my view, a great writer, as well as a physician, an outstanding physician. I see myself as a physician, but not as a writer, even though I've done about 40 books. But rather,
only 40. Wow.
But rather as a William Jamesian, almost like a footnote to William James. Remember, William James said that everything comes out of experience. And my great curiosity was for experience. How do people live with suffering? How do they respond to it? How do practitioners of very different kinds in different local worlds, worlds across the seas and worlds neighboring each other, how do they do things distinctively? And so it was that sort of focus on experience that I think sums up what my interest has been, with the one caveat: to use experience in order to help others.
Wonderful, wonderful. That brings us nicely to your new book, which is a real departure in the sense that it's intensely personal. I'm sure you wished never to have to write a book like this, and yet it's such a gift. The Soul of Care, where, without giving too much away, you really talk about your transition from being a academic and a physician to becoming a caregiver. And I just want to quote to you from a passage here you say in this book, care is also about the vital presence, the liveliness and fullness of being of both the caregiver and the care recipient. Acts of caring call that presence out from within us. Care does not end with death, but involves actively caring for memories. So tell us a little bit about the genesis of this book, and then I'd like to shift this discussion, if I may, for a little bit to talking about care, because it's a paradox how healthcare is the business that Eric and I and you are involved with, and yet care, especially the way you construct it, is almost tangential to the discussion of healthcare and healthcare reform. So tell us a bit about this book and how it came about.
Right. Yeah. As you suggested, was a painful one to write. Well, for a decade, a little over a decade, I took care of my late wife, Joan Kleinman, who had early onset Alzheimer's disease. And not only did she have Alzheimer's disease, but it was a particularly frustrating kind because it started in the occipital lobes of her brain, which are responsible, among other things, for the interpretation of images. So she was functionally blind as well as suffering from dementia. And this was very cruel because she was a very visual person who was a fine painter and calligrapher in the Chinese tradition. And so as this awful decade developed, I began to realize that it was as if a veil of ignorance was pulled away from my eyes. And I was seeing caregiving from the inside as a family carer, and realizing that with all these decades of experience I had had doing research on care and being an active clinician, I really had lost the sense of what caregiving is for a family member. And it was so striking and powerfully so to me that I felt I wanted to write a book that was at once, as you point out, raw in its personal nature, deeply raw, I think, and in the other sense, could generalize from my individual example to care more generally. So, but the first thing was, what did I mean by care? And how is it possible, for example, to have healthcare without care, which is, I think, where we're headed in the crisis of healthcare right now? Well, by care, I meant just the things you read, and I'll just illustrate them and bring them forward a little more. I meant, first of all, the nature of the relationship that caregivers have with each other, since I think that's the most fundamental dimension of care. It's a relationship. And it's a relationship in which once we focus on the care, it's easy to forget about the care recipient, that is the patient or family member who needs care, but who is just as important, if not more important, than the caregiver. And in this relationship, there is, as I've both experienced it and looked at it cross-culturally, there is a kind of gift exchange. There's an exchange of gifts in an anthropological sense, that the care recipient gives the gift of their vulnerability and their need to be helped, assisted. And in turn, the caregiver gives the gift of their involvement and their assistance. And that's tied, I think, also to presence, their presence. So we're all familiar with the criticism of medicine today that frequently the doctor is so absorbed in the screen on their computer that they have their back turned to the patient and are not present, are matter of fact. But I think when you look at family care, it involves a kind of a deep presence. It's that relationship that's begun long before and will end later, and is not just a one-time shot, but something of intimacy and tension, because even for the most loving and committed caregiver, care is tough work. It's hard physical work. It's tough emotional work. It's moral work as well. And so besides this presence, I think there's also the issue of enduring. You have a long illness experience of a disorder that cannot be cured, but has to be managed. In that long illness experience, I really don't think that any of us are truly resilient, where we're like rubber bands and we simply spring back to what we were before. So demanding, so difficult is this experience. And I think the real issue, and it's one that we don't like to talk about in the United States because it doesn't have a kind of Hollywood ending, is enduring. How do we endure? That's what I felt. I felt my 10 years of taking care of my wife, I was challenged to the core and wasn't sure I could endure. I felt at times I was enduring the unendurable. And so what is enduring about? How do we keep going? Because of my own experience, I looked at and spoke with many other family caregivers and was astonished how many of them felt they came to a wall and couldn't get over this wall. And yet, because of their love and their concern for the person they were taking care of in the family, they got over the wall. They made themselves get up and get over the wall and keep going. And I was very impressed with how enduring is critical to care. And then the last part is which you also mentioned, was the care. It's surprising. I learned this from my personal experience. I should have known it from my professional experience. But care does not end with the death of the person who you're caring for. You're caring for memories after that. The clinician cares for memories, remembering how to think about the care and how to perhaps use a particular case to improve his care in the future. The family member, of course, is rebuilding a story about one's life and one's family. And central to that is the memory of the care you gave, what you've gone through, the attention to those memories, their ordering, the time we spend developing them. It becomes a very important part of our lives after the practical acts of care no longer need be given because the person has passed. So those are the kinds of things that I was concerned with. And I came to realize, if I can just complete the thought, I came to realize two things. One, that care was disappearing from clinical medicine, that clinicians had become so tied up with technologies and so not tied up with delivering the technologies effectively, that they were forgetting about the role that care plays. And that even in families, given the limited time that family members have today, the fact that both husbands and wives work, that this was women's work in the past, and men in our time, no matter how much woke and liberated they claim to be, are not picking up the tasks of care. There's some question as to whether in the future, even in families, we'll have care.
Yeah, I mean, Arthur, I think what you've provided in The Soul of Care is an extraordinary book, and in many ways a gut-wrenching story. And you've defined care so elegantly. The other word, of course, is soul, that you haven't really delved into. I thought you really captured this well in the recent Lancet piece you authored in August, which I just want to read one sentence from it, where it's the soul in medicine, as you wrote in The Soul of Care. And you wrote, I find expression soulless, a resonant one, to depict what is happening to caregiving in medicine in our times, where the health system's goals of efficiency and cost effectiveness, new technological requirements that absorb the clinician's alertness and attention, and the sheer pressure of insufficient time to listen and explain have a dire effect on providing the best of care. Can you amplify on that?
Yeah, well, I think that is, in fact, the case. If my colleague Atul Gawande has written a terrific piece that you probably read in the New Yorker about based on the EPIC system and Partners Health System in Boston. It's their electronic medical record. And Atul pointed out that so complicated is this medical record, so difficult to use. It was developed really without the idea of care in mind, that the clinician's got to spend virtually all her time trying to work with it in order to make any sense of it and use it to provide information about the patient critical to the treatment. So in a setting like that, the whole attention of the clinician is away from the patient. The second thing that's happened, and maybe Abraham, you'd really be the expert on this, but it's as a consultation psychiatrist, that is a psychiatrist who works with people in internal medicine and surgery, I've been very impressed by how residents today in internal medicine seem to distrust their clinical skills of physical examination and to want to jump right away to objective test results that come from the various machines we work with, which are more precise than we can be with auscultation and with other acts of physical diagnosis. And yet, physical diagnosis done the way you do it, and the way I've felt it should be done, is a wonderful example of caregiving. It's the laying on of hands. It's the supporting of the person. It's the resonant sense that we're in this together, that I'm here with you. That's not the way that I'm seeing the physical exam being carried out today. It's much more perfunctory. It's a sort of a run-up to doing the tests that really are more precise. And it's sort of lost its ability to be crucial to the actual caregiving by touching and by connecting. So I think that's, a part of my concern. Another part of my concern is that when you start a clinical interaction in medicine, bioethicists have clearly pointed out that the first actions are acknowledgement and affirmation. The doctor acknowledges and affirms the patient for being there legitimately with a problem that needs attention and affirms their suffering. And in turn, the patient affirms the doctor's right to explore their body and to ask deep questions. And I think that if you have your back turned to the patient, if you're focused on the technology of the computer, it's very difficult to establish this acknowledgement and affirmation of the humanness of the person. And hence you begin the patient-doctor interview without that human connection being acknowledged and affirmed. And I think that's disastrous, frankly.
I'd like to pause our discussion here for a brief message from Medscape, and then we'll be back to continue our discussion with Arthur and Eric.
You can read the transcript from this podcast and find more Medicine and the Machine episodes at medscape.com/machine. Medscape news, features, clinical tools, and education are available for free. Stay on the pulse of medicine. Visit medscape.com.
Welcome back. This is Abraham Verghese, and I'm here with my co-host, Eric Topol, and our guest, Arthur Kleinman. So Arthur, I'd like to ask you about something that I found really extraordinary. If you plot the course of your wife's illness, the trajectory of it, medical diagnosis was a small element of it early on. But then if you sort of look at the percentage of time of people who really mattered to you and your wife during this long course of illness, there are very few physicians involved, and most of them have bit parts that are often detrimental to the care, not necessarily helpful. And the single most important individual you acknowledge again and again was the professional caregiver who worked with you. What are we going to do sort of as a nation when we talk about healthcare reform, when that is the person we need much more of from the sounds of it, and much less of the high-tech stuff that we spend a lot of time?
It's a great question. And so I could not have taken care of my wife for 10 years doing the things I had to do if it weren't for the assistance of a terrific home health aide. And this was a woman of Irish background who came from a family in which there were multiple generations of home health aides. It was what the family did, and she was just great with Joan. And not only was she great in helping, she worked 5 days a week, 9 to 5. And as she pointed out to me, I worked 2 days of the weekend, and then 5 p.m. to 9 in the morning, 5 days of the week. And the respite that she gave me, the chance to get away and do my work, made me a much more successful caregiver. And in fact, I just don't think I could have done it without her. Now, I lucked out. No one, the astonishing thing was that the medical specialty that is responsible for, sees as its subject dementia and neurodegenerative disorders and stroke, that is neurology, is so organized around diagnosis and a few medicines, most of which are limited in their effectiveness, that the profession itself seemed to have come to a conclusion it has nothing to do with aftercare. And so although some of the great neurologists of the country are at Harvard Medical School, and they made the diagnosis of Joan's Alzheimer's disease about at least a year before it probably would have been made otherwise. And they all wanted to help me. They knew me well and wanted to help me. Not a one said anything about the care that I would have to provide and what Joan would be going through. And it astonished me. In fact, no one recommended a home health aide for me, which, as I just suggested, turned out to be absolutely crucial. And no one said anything about how I'd have to reconfigure the house so that Joan would be more comfortable there and I could take better care of her. No one really mentioned anything about what the day-to-day living experience would be like and where I would need assistance and how I could get it. And that was astonishing. And I went back to certain of my neurological colleagues and I realized that they just didn't see this as their purview, which is, I think, very sad. And they, nor had they organized, as far as I could see, for Alzheimer's, the kind of cancer care team that we take for granted in the area of oncology, where if the oncologist can't do it, there's a social worker or a PT or someone else who will step in and do the kind of care that's needed. So I think this is a huge problem, simply huge problem for the neurodegenerative disorders. And I don't see an easy solution to it. In fact, I think it may get worse. So for example, the home health aides, who are they? By and large, they come from, as in my example, of poor women, often women of color, women who do not necessarily want even to go into home health care, but it's about the only job open to them. And this is certainly true of recent immigrants to the United States, who often dominate the field. In Boston, it's mostly Haitian immigrants who do this. And yet they do a remarkable job. Along the way in both home care and when Joan had to go into a cognitive care unit, her support from home health aides and from health aides in the clinic was just tremendous. They pick up where physicians fall off. But, they're decreasing in number as people find they can do other things, make more money, it's so poorly paid, have more status, et cetera. They're dropping out of home health care as soon as they can. And, we don't even have good studies. As a researcher, I was astonished to discover that we have hardly any studies that tell us what's the content of the work that home health aides actually do. How well are they prepared for it? How well do they deliver it? So all these things struck me as a sign that care is just not there in the minds of the people who sort of organize the domain of healthcare for dementia and neurodegenerative diseases generally. And here's another part of it that was astonishing to me as I began to think this through. We're constantly talking about the quality of care, but if you look at care the way I've talked about it, we have no measures of the quality of care. We don't measure relationships. We don't measure explanations. We don't measure listening. We don't measure skills in touching and supporting some. We don't measure any of the things that are central to caregiving, and yet we claim quality care. So what do we do when we say that? We're substituting institutional measures of efficiency, basically, for measures of care. And I think that if more people were aware of that, if they were aware that we just don't examine quality, they would be more concerned about this, what I see as a great crisis.
I'm struck that in Eric Topol's latest book, Deep Medicine, he talks about how, in a way, machines have eclipsed us in terms of their capability. At least theoretically, they've gotten to that point, and yet it indicates that this is the moment for us to get better at our humanness, so to speak. And I think that, Eric, I'm not speaking for you, but in a way, I think you were speaking to very much this new frontier that we've managed to dodge because we've been so busy with our diagnostic instruments and therapies. But I think we have to come back to this kind of humanness because the machine can never do any of this for us.
Right, Abraham. And that's why I thought that you grabbed me, Arthur, with the term soulless and how medicine has moved in that direction. And in fact, as you pointed out, that we don't even talk about soul, no less think about it. And the question, of course, is that with technology, which is counterintuitive, since time is a big factor, the gift of time, and you go back to the neurologists that didn't talk to you and your wife about what was coming forth in the condition, in her condition, and in your caregiving. A lot of this comes down to that there's so little time to connect. The exam is another part of that, as you've mentioned. If we can restore that time, because we don't want to leave everybody here in a downcast way, do you think that we could get the soul back in medicine, Arthur?
I believe so. I believe that, first of all, there are examples of Abraham and you as are outstanding examples of the fact that we have practitioners who are able to bring the soul to bear or tend to it. But I think that we've got to try at many different levels, and to be honest about the lack of resources. We need resources. So to begin with, I'd begin with families. I think that family members who provide care are providing it uncompensated. They've got to be compensated. And I think the country will come to this recognition laterally after we begin to realize that if there was a 10% decrease in the number of families who care for people with dementia, neurodegenerative diseases, end-stage disorders of every kind, if there was a 10% decrease, it would overwhelm all the hospitals, all the nursing homes, and all the facilities we have. And so we've got to keep this going. And the second thing is the home health aides and long-term care insurance that goes with it. We just don't provide those things. If we did, and they are provided in Japan, in Scandinavia, we would have a different family setting. Then when we think about medical school itself and the practice of medicine, in certain of the German medical schools and in a few of the Dutch medical schools, especially Leiden, which was the great medical school in the 17th century, before students start medical school, they spend a week or 10 days in the homes of families with patients who have serious end-stage disorders, very serious disabilities, and chronic conditions. And all they're expected to do is to deliver care of a family kind. Now, these are medical students, but they're just starting, and they're doing the cleaning, the washing, the bathing, the feeding, etc. And I happen to have been a visiting professor at Leiden a few years ago, and I spoke to a number of their faculty who had gone through this program, and they told me it was the single most important part of medical school. We need that in the United States. That would remind doctors that it all begins by seeing the life world in which illness is experienced. Recently, you both may have seen this. The National Academy of Medicine put out a report called Families Caring for an Aging America, in which it pointed out that it was commonplace today for an elderly patient to have a surgical procedure and to return home after 2 or 3 days in the hospital with 2 tubes coming out of the abdomen, in which no one had explained to the family what the tubes do, how you take care of them. And the family was petrified that they would infect the patient, that they would do something disastrous in the care of the patient, and no one simply had explained to family members. And so I think that right through the healthcare system, if a chair of an academic department of medicine or surgery or psychiatry demands that the service chief in cardiology or nephrology demonstrates high quality caregiving practices, then I think that's modeled by the rest of the clinical team down to the medical student. But what gets modeled in our time is the opposite of that. We've turned over basically the clinical teaching of medical students to residents, and the 3 of us were all residents. When you're a resident, I remember my residency at Yale, you're a survivor. You want to get out of the damn hospital. You cut every, you're taking all the shortcuts in order to get out. And in so doing, you're sort of giving a reverse message to the medical students. They've learned all of these things that they should be doing, from taking the history carefully to demonstrating empathy, and you're doing all the opposite things. And they come to see that if the resident is doing it, well, that's the way it is. So again, we got to change the way we teach medical students. And this is stuff you guys know. And all over the country, I've been for the last 5 years or so, I've been giving lectures at many medical schools across the US, and I've been really impressed with the fact that virtually every medical school is trying something new with regard to training medical students to be more human in their care. Sometimes it's in the medical humanities, sometimes it's in the doctor-patient course. It's, everyone is doing something different. But it seems to me that this is promising, that there's an awareness that we can't go on like this any further, that we've got to return to certain core dimensions of healthcare in which caregiving is crucial and in which doctors are able to participate. And I think we're not going to let doctors off the hook in the future. I was impressed with the experience with my wife by the number of family members I encountered who were taking care of their family member with Alzheimer's, all of whom felt frustrated and angry. Frustrated about how difficult the care was, angry about the fact that they felt that the professional medical side seemed cut off from what they were experiencing. So that's the source of my optimism.
Arthur, I think your book is really going to be a siren call for change, and you've been the front runner and the bringer of new ways of thinking for so many years, and this will be perhaps your most important legacy. I want to read the last sentence of the book because I think it's so powerful. It's a bit about writing and it's a bit about you. It says, I am letting go of Joan by completing a long drawn out grieving process with this living testimonial. And in another equally uncanny sense, the writing has enabled me to allow my old self to slip away and to be replaced by the author of this book, who is not only a carer of memories, but decidedly a different human being. You really have captured this personal transformation, but I think it's going to help all of us to plot some new course, because you're right, we definitely need a sea change in the way we give care.
Thank you both for having me on the program, and I wish you only the best of success for this important enterprise you're embarked on.
And
Well, we're so appreciative, Arthur, and The Soul of Care is just an extraordinary book. Thanks so much for pulling that together.
All the best.
Thank you.